Okay, so the conversation we're having now is about the steps for an outbreak investigation. I had said in the previous slide that when you're investigating an outbreak, it's important to know that because you are dealing with an unexpected event, there is need to act quickly. There is need for activities that will bring that untoward event quickly under control. There is need for you to be coordinated, and most of the time it's interdisciplinary interactions. And then there would be some practical activities carried out and done in the field and in the community. To be able to be successful at all of these, there is a need for a systematic approach, an approach that has steps that you can follow, that you can modify, that you can use to ensure that you're not leaving anything important thing out and you're able to do this. So typically in investigating any outbreak, these are the steps that will be used. There are two major, or multiple parts of these steps. One is to identify what's going on. The other is to begin to respond, and then the final one is to report it. So let us look at how that happens one after the, the other. And another thing to note is that even though you're seeing these 10 steps and you're seeing them in a certain order, situation may demand that you adjust or edit the way that you use these steps and take maybe one before the other, or take two or three steps and at the same time. It happening at the same time, not necessarily that you must finish one before you go and start doing the other. Um, these are the 10 steps. We run through it and then we take them one by one. So the first thing is to establish that there's an outbreak in the first place. Establish that there's an outbreak in the first place. So you ask yourself, does it meet the definition of an outbreak? Next, you want to verify the diagnosis. Are you dealing with, is it actually COVID-19? Is it actually Ebola? Is it actually measles? Is that what I'm dealing with? I may be thinking that it is measles, meanwhile, it's actually chickenpox. So, am I able to verify the diagnosis? And then define a case. What's a case? Who has the disease? And then what are the numbers of persons that have that disease? So, define the case and count it. Arrange your data in terms of time, person, and place. That's descriptive epidemiology. The number of people who have it, you have to organize them by time, person, and place characteristics. Then you also need to determine who is at risk, and what puts people at risk. Develop a hypothesis for that. Compare your hypothesis with established facts, test the hypothesis, do a systematic study or research into what's going on, prepare a report, execute control and preventive measures. All right. So let's take it one by one. One is establish the existence of an outbreak. So, before you even go to start establishing the existence of an outbreak, you're going to have to prepare for field work. That's the preparatory phase. You have to ensure that one, you have a team. EPR is emergency preparedness response team, emergency preparedness response team, or epidemic preparedness response team. You need to have a team in place. You have to have a plan. You have to have an RRT is rapid response team. So basically, some people call it RRU, rapid response units. They have to be there, trained, knowing what to do, and be able to be activated within a short time. You need all the supplies and equipment that you will be requiring, things to collect samples, medical supplies to begin to treat, um, uh, ways of communicating with people, all the forms. Remember surveillance form 001A, 001A and 001B and 001C. You need those forms available with you to be able to fill in information about patients in an emergency, about persons who are affected by emergency, by these epidemics. Um, Consult, you get your team in place, you consult, you get your materials in place, you clarify yours and the roles of others, make sure that the team has a leader. Now you are ready to go. Um, while you're talking about establishing the existence of the outbreak, you need to look at clinical findings, visit the patients, interview them, examine for signs and symptoms, do a laboratory investigation, choose a working case definition. Who is a case, who is not a case? I mean, and sometimes the case definition is as wide as possible for a particular reason. It's as wide as possible for a particular reason. The reason is that you want to be able to drag in as many, you don't want to miss anything that may be a case. But that's why something like case definition for measles is fever and a rash. It doesn't even say what type of rash. Suspected case of measles, child under 5, fever and a rash. What happens when you collect the sample and send it for diagnosis, you will find it to a confirmed case, and see whether the person has the measles virus, and so on and so forth. So you're asking yourself, are we dealing with an outbreak? Very important. And at the same time that you're asking yourself, are we dealing with an outbreak? You can also be verifying the diagnosis. So you see, you don't have to wait until, okay, I'm dealing with an outbreak, then you wait 1 week to confirm you're doing it before you now say, okay, let's collect sample. No, you may have to actually be doing it at the same time. You're examining the person for signs and symptoms. You're asking how many people have this disease. You're visiting one by one, and you're collecting samples at the same time to send to the laboratory for diagnosis. You're trying to identify a link between cases. You're asking yourself, is it higher than expected? You're doing all of that. You can also collect samples for diagnosis. All right. So you ask yourself, because there are seasonalities related to certain illnesses where, of course, we know diarrheal diseases, the number of persons affected by diarrheal disease goes up in the dry season because sources of water are few and people are likely to drink polluted sources of water because they're looking for water, as against the rainy season where you have more access to water, clean water to an extent. So you have those type of challenges that come up. You have more of insect borne illnesses during the rainy season than you have during the dry season because insects are more abundant during the rain. So those are the kind of things you'll be looking at. Is there a seasonality pattern to it? Uh, the number we're observing, is it, how does it compare to what we are expecting? Uh, and so on and so forth. So this is usually, so there was a curve like this. It's called the epi curve. It's called the epi curve. There was a curve like this for COVID, where you have the number of cases every day and you're plotting. So if you open that type of graph and you're plotting number of cases every day, and then you see a spike, just like you're seeing here, you see a spike by day 10. You're seeing it. In fact, it started actually climbing from day 1. You see that day 1 was the lowest on this side while the epidemic was forming. And then you see the numbers gradually increasing. And then you just see, poof, the thing just explodes. You have a steep increase. It peaks, and then you now have some, sharp decline in number of cases. So this tells you, wait to it's not this thing I'm saying is not, because if it were supposed to be endemic, I don't know if you can see my cursor. If it was supposed to be endemic, you see that the line is almost on the same level. Maybe to go up a bit, to come down a bit, but it's almost like that. Either straight or wavy, hardly really be straight, but we don't have the exact numbers week by day, but it'd be a bit wavy and so on. So it's endemic, but used to it in this prevalence. But when it shoots up like this, that begins to tell you this is not the usual sequence of deaths. Yeah, seeing that. So this actually shows you Usually, practically, what happens? You know, practically, what happens? It shows you what happens. You have a first case, usually to start with a first case. And of that first case will either, you know, infect other people or lead to secondary cases and so on and so forth. Usually, it starts becoming noticeable when the numbers get to a certain threshold of cluster of cases that alerts to say, a report may now come or surveillance may pick it up. We're seeing numbers that we do not expect. These numbers above our expectation. By the time you talk about lab confirmation, many times it's late because our lab systems often don't catch up with what's going on. And then, of course, you start having response and so on and so on. This is usual. This is how you would see, but we don't want this. We want something much faster than this in our own outbreak response. And you see that? Can you see that it's closer now? So you don't have to respond, you don't have to wait until the epidemic's almost over for you to start to respond. This is what it's supposed to look like. If you know your outbreak investigation and response properly, the outbreak will not be almost over before you start to respond. So if you respond properly, you've shortened the curve, and all these other cases are potentially prevented. This is the reason why outbreak investigation is so important, because once you come in and you follow the processes pretty rapidly, you're able to bring in response and stop morbidity and mortality from going too much while you're just there as a bystander studying how people are ill and how people are dying. Okay, so if you get the confirmation, remember step is one of the steps is confirm the diagnosis and confirm that there is an outbreak. Is there really an outbreak? When you confirm the diagnosis, you can actually start control measures immediately at individual, at household, family, and at community levels. So interventions and control measures will not just be on individuals. It may also be on their families. It may also be in their homes. It may also be in the community in general. What are some of the things that can happen? One of the things is prophylaxis. When you're talking about control measures in an epidemic situation, prophylaxis is what a drug that can be given to prevent the occurrence of a disease in people who don't have that disease presenting yet. So they aren't yet, people aren't yet ill, or you start because they've been exposed. You do not have evidence that they're infected, but just because they've been exposed, you start to provide treatments. A typical example of this is preventive ribavirin treatments for Lassa fever. Anybody who's exposed, health worker exposed, anybody exposed to a suspected case of Lassa, the teaching is that you immediately start to give tablet ribavirin. And that is supposed to help that if for any reason that exposure leads to infection, there's already ribavirin in the system to counter it. And as it has been said to be the difference between survival or not, early administration of prophylaxis. You can also have isolation. Isolation, this is where you get isolation center, whatever stuff like that from isolation. And isolation is really about keeping people away. Now, I must explain that there's a difference between quarantine and isolation. There's a difference between quarantine and isolation, and I need to explain what the difference is. Quarantine is separating someone from others, and that person, that someone, is someone who is suspected to have been in contact with a suspected or confirmed case of a disease. Anyone that has been in contact with a suspected or confirmed case of a disease will undergo quarantine. And quarantine is keep them away from other people and monitor them to see if they develop the disease they've been exposed to. So at this point, there is no diagnosis. Nobody has said they have disease. So you cannot quarantine someone who has already manifested signs and symptoms, who already has disease. No. You quarantine people who have been in contact, who have been exposed to a particular disease, but are yet not manifesting any signs of symptoms. Those are kind of the big ones. So you keep them for the longest incubation period possible for that particular disease. A typical example is Ebola. Ebola's incubation period was 10 to 14 days. The median being 7 days, the longest being 14 days. So if you suspect that someone may have been in contact with a suspected or confirmed case of Ebola, you need to confine that person to somewhere, a room, a hotel, whatever it is, a facility, for 14 days. At the end of the 14th day, the person doesn't fall ill. On the 15th day, the person is discharged. I almost said discharged and acquitted, but discharged as not having disease. It's different from isolation, in which it is confirmed that someone has the disease or the person has manifested signs and symptoms of the disease. It's either confirmed or the person has begun to manifest signs and symptoms of the disease. And what you do in isolation, throughout isolation achieves two purposes. One, it keeps that person away from infecting others while the person is still interacting, learning, and experiencing life and all of that. On two, it provides opportunity for intensive treatment of persons who are either infected and confirmed cases of the disease. The other thing is that you need public engagement, and this is where the risk communication and community engagement groups come in. You need public engagement because the public needs to know what's happening, what's going on, what they should do, and all of that. Then putting hygienic measures in place, whether you want to do decontamination or you want to do fumigation. So what do you really want to do around the environmental or hygiene management of the matter? And any other thing that you can think about and come up with for control measures. Vaccination, for example. Okay, vaccination, for example, becomes a beautiful control measure. Then, of course, you may need further investigation. Do you know the cause? How serious are the cases? Are cases occurring even though you are trying to intervene? What's going on with the public? How science, what's happening? Are people interested in it? Is it causing a lot of, you can imagine COVID caused a lot of issues. I remember I was on radio multiple times trying to convince people COVID is real, wear the mask, this, that. There's no public pressure to end lockdown, no public pressure to open schools, and so on, so on, and so on. All right. Let's skip this. So when you're talking about outbreak control team, of course, the epidemiology, I told you this, I said earlier on that it needs to be a multidisciplinary team. Epidemiologists, microbiologists, clinician, environmentalists, government, press, media personnel, and so on and so forth. And the team needs to be the one to control or coordinate the field investigation and field activities. And each of them have their roles. Each of them have their roles. You actually may be the one being called on sometime in the future to lead the team and to coordinate. You need to know what the roles are of the various team members in that group. I won't take you through each of them one after the other, but just know there's a multidisciplinary team and each person has their role. So I've used the word case definition a couple of times. For you to know what is going on, you need to be able to identify diagnosis, identify cases of the disease. Um, uh, Identify cases of the disease. So, for example, you need to have a case definition. Different diseases have different case definitions. The advantage of a case definition is that it gives you a uniform way to identify a suspected case or a confirmed case of a disease worldwide. It's standardized. So, in case of a disease in Nigeria, it's the same case in Namibia, it's the same case in Uganda, it's the same case in Ghana, it's the same case in the United Kingdom. So when you say we admitted one confirmed, we have a suspected case of Ebola. Using that case definition, everybody is on the same page. Everybody knows that it is not Lassa. It is Ebola. It is not measles. It is Ebola. So it helps to give you um, very, very sensitive and very specific as well. Yes, so I see the chat. Let me correct myself. It is 21 days. Ebola was actually 21 days, longest incubation period. It's COVID that was 14 days, longest incubation period. All right. So, uh, so this is still talking about a case definition. And of course, there are multiple levels of case definition. So you have a suspected case, you have probable case, and you have confirmed case. You need to know what these definitions are. Starting from confirmed case, that's the easiest. You have a laboratory investigation identifying the etiological agent, identifying the causative agent. That's a confirmed case. Whether the person has signs or symptoms or not, whether the person is presenting with anything or not, a confirmed case, somebody takes samples and runs it in the laboratory and it is confirmed that the person has a particular is able to isolate the causative agent for that particular disease. It's a confirmed case. A suspected case is a case that meets the definition of clinical signs, symptoms, and oftentimes epidemiological link. So signs, symptoms, and an epidemiological link. Of course, we know what signs and symptoms are. What is an epidemiological link? History of contact with a suspected or confirmed case. History of contact with a suspected or confirmed case. Now, a probable case is one in which there is an epidemiological link, but you may not have access to that person for a confirmation, a laboratory confirmation. You are unable to have a laboratory confirmation, but the signs are there, the symptoms are there, and there is an epidemiological link beyond a shadow of doubt. In that particular situation, what you probably have a probable case. So let me give you an example. When the first person who got Ebola into River State came into the state, uh, when he first came into the state, went to the hospital, was attended to by a doctor, or the doctor Sarah that attended to the first case of Ebola. That doctor fell ill and died before sample could be collected for Ebola. But because we know this doctor treated the first case of Ebola, we know the doctor was ill, we know the signs and symptoms. It's very easy to say, most likely, this doctor died of Ebola. So that's a probable case. We're not quite certain because we cannot do laboratory investigation. Every other thing is intact. Every other thing is intact, such that we are almost sure that it's not likely to be anything else. So it's a bit stronger than suspected, but not as strong as confirmed. So we've talked about we've talked about verify and confirm that there is an epidemic or there's an outbreak, identify the number of cases, count the number of cases, have a case definition, count, have verify the diagnosis. Sorry, the next thing is to count cases. Count cases. So counting of cases, identifying and counting of cases usually occurs through uh, active surveillance or a combination of passive and active surveillance. So you're looking at the records of healthcare facilities to see whether they have any records of suspected cases. But sometimes you also want to do active surveillance in which you would go to groups such as hospitals, veterinary clinics, laboratories, schools, workplace, and just check all the information to be sure that you are able to identify and pick and count the number of cases on it. All right. So you need to obtain information from each of these cases. And this is where the form 001A comes in. From 001A, you have the information for each person who is suspected to have a particular disease that is an outbreak or epidemic. So you need to provide information. And again, remember I said this is the same information that will be put on the line list. So this is like an Excel spreadsheet. Then there's need to analyze the data, descriptive statistics, time, person, and place characteristics. A total of 200 people were identified as suspected cases of measles in a particular community. We want to go and talk about what is the age distribution, what is the sex distribution, what's the socioeconomic status, duration of illness, and so on and so forth. So it's descriptive analysis is very, very important. And see the things that we use to describe time, person, and place characteristics. Time, person, and place characteristics. When, who, where. Time, person, and place characteristics. So that's it. Those are the kind of questions you want to ask. Who are the cases? Where did they live? When did they become ill? So you're looking at that. And it's really important to do that because it starts to give you an idea of what may be responsible. What may be responsible? What is the pathogen that we're dealing with here? Where is it coming from? Because patterns will emerge. If you're looking at that thing, you're looking at time, person, and place characteristics. It's so easy to see patterns. So you can now see what the transmission, you may see what the transmission pattern looks like. You may be able to identify a source. If, for example, the number of cases in a particular area is far more than another area, then that may be the source. Again, the index case, the source, the person who first of all had the infection, and probably the one who spread to other people in that particular geographical location helps you with helps you to assess the source of the infection. Because you may be able to go and identify that person who is in that case and find out the person to dig a little bit deeper to identify the source of the infection. What is the disease causative agent there? You could be able to see the average number of days people were ill, the type of illness they talked about, and all of that can help you to say, oh yeah, this is likely to be the pathogen responsible. So it's very useful for us to create a descriptive epidemiology. Okay. And then the descriptive epidemiology, you can now plot your epi curve. Epi curve is the number of cases versus the days of occurrence. So each day you just do a number of cases. Each day you do a number of cases. And sometimes you can split this epi curve into a male and female distribution or an age sex distribution. And you can disaggregate by age and sex and start to see what is going on. And of course, the type of epidemics becomes obvious when you see the way the epi curve is. When you see the way the epi curve is, so you have what we call a point source epidemic, and you have what we call a propagated source epidemic. Point source means that virtually everybody who is ill with a particular outbreak, the disease causing agent for an outbreak, almost everybody gets infected from one person. So you see clustering. You see it looking as if um that's the one here. You see cluster, you see looking as if what's going on in small numbers and it goes up and it peaks and then it comes down and you just see a number of cases and it clustering at about and then you see many people are likely to be picking at a particular point in time. See 20 on day three, see 20 people. So it's likely these 20 people were actually exposed on day one or this from a singular source. So that's what a point source epidemic looks like. This is continuing common source, or otherwise called propagated source. That means that one person infects the other person infects people, the other person infects people, like that. So you have multiple people being infected. So this is that third graph. You have multiple people getting infected. So you see the thing in waves, waxes and wanes, waxes and wanes, waxes and wanes. That's exactly how COVID was. COVID wasn't a point source epidemic, it was a propagated source. You have it waxing and waning, waxing and waning. Then you can have a continuing common source. It's from one person, but the person, for example, let me give an example of typhoid. There's a story of typhoid Mary, who was said to have been a singular source of typhoid infection for thousands of people in the UK many years ago. So she was just common source, but she was just slowly infecting people, slowly infecting people, slowly infecting people, slowly infecting people. Sometimes the number of people she have access to are higher, sometimes lower, and so on and so forth. And then somebody else picks it, that person continues to slowly infect people like that. Unlike this one, where multiple people get infected and they keep spreading it and propagating it, it's difficult for you to put a finger on where it's probably originating from. And of course, you know that point source epidemics are usually easier to handle and manage than propagated source epidemics. All right, to make progress to the next one. You need to develop a hypothesis. Hypothesis is what is your best guess about what what the risk factors are for the illness. What's going on? How are people getting ill? What is the thing that is promoting this epidemic? What's the mode of transmission and all of that? So looking at the data that you have already from descriptive epidemiology and discussing it with some bright-headed, bright-eyed, level-headed, intelligent people can help you start to develop a hypothesis, which you will test. But you need to first of all develop a thought or a guess about what is going on and why it is happening the way it is happening. So, for example, you might see that there was, trying to think about it and find out what's going on. There is an outbreak of measles, and you check and you find out that, oh, it's likely that the last measles campaign wasn't properly done, and there were many people who were left behind from that campaign. Hence, they formed themselves a good resource place or location for the uh, disease. So you compare your hypothesis, so you develop the hypothesis, um, you compare the hypothesis with facts. You have gotten information, you have collected data, and then you want to test your hypothesis. And the best way to test hypothesis is to carry out analytical studies. We've talked about descriptive studies, and we've talked about analytical studies. Analytical studies helps you to test your hypothesis. So, for example, the typical um, um, story, classical story we tell about the first person who used hypothesis testing to identify the source and the risk factor for a particular epidemic was John Snow. So the story goes that John Snow identified the fact that, I mean, he just took a map of that environment and went door to door to identify everybody who had that particular plague. And I mean, people were dying too. So he put a dot on every geographical location where people had died from that disease. And by doing that, he saw a clustering. He saw very, very thick dots, multiple dots clustered together in two particular areas in town. And then in also one aspect, one area that was relatively dot free. That means there were no cases in that area. And he wanted to find out what was different between these places. So his cohorts, one group was, so what he did was basically like a case control study. People who were ill, disease that died from one area of town, compared them to people who were never ill, who were never diseased, who didn't die in another part of town, and found out what was different in their practice, and found out that the place where there was little or no deaths or even disease infections were getting their water supply from as potable water from a company where most of the people there worked. So the factory was supplying them with potable water, while these other people were drinking water from the Thames River. And then it was a terribly boom messed up place with, they were getting their water from there. Where water was being pumped untreated into their community uh, borehole, monopump, whatever setup and like that. And so to further test this hypothesis, now entered into a cohort study. He went to one place and removed the pump. He removed the water pump, disabled it. No water from that place. And told everybody can drink water from the other place where they were getting their water from the factory, from the company that they were working with. And within a short period of time, the number of cases dropped significantly. The number of cases dropped significantly. And I was able to say, so what happens here is that it's actually the drink of the water. It's actually the source of the water. So you may not do something as dramatic, or you probably will do something, you know, something to try to say, let's identify it. Let's know what's going on. Let's put place so that you can put measures in place. So the source of the agent, the mode of transmission, what are the risk factors, and so on and so forth. Honestly, you have to start implementing control measures, and you will not wait until you finish doing research, get ethics approval, finish your cohort study or your case control study before you start implementing control measures. That will be wicked. So you start implementing control measures almost immediately. Mm. And of course, by knowing, understanding the disease, the natural history, the infectious agents, the environment, and also the dynamics of the host characteristics, you can actually attack this disease condition that is causing this outbreak or this pandemic, epidemic, and address it. While you're doing that, don't just do it and go. You have to be told if you're coming from out, if it's not, I mean, it's not local response team, the response team coming from either local government or state government or even federal government. You need to build the capacity of the local people on ground because you will not be there forever. So all the control measures that are at your disposal, you would use them. Sometimes it is remove the source of the contamination, so you might purify drinking water and so on and so forth, make sure the water is potable. Or sometimes you may just want to protect people from exposure by giving them prophylaxis or removing them from the place where they can get infected. You may want to talk of giving them vaccination. You may want to identify infected persons and isolate them while you are providing treatment, and so on and so forth. So on and so forth. So this is all Then there's a point of where you have to prepare reports. You need to be able to communicate what you have found, put together some messages for the public, also come up with ideas that can influence public health policy. It's in the course of intervention and all those things about wear mask, 2 meter distance, blah blah blah, that came out for COVID that we were using at that time of our public health measure. I mean, we had to do flyers and other banners and radio announcements, so many things just to inform people that that is what is going on. All right, so I'm going to stop here. We'll take questions and answers, and then I'll take a short quiz before we um, before we call it a day.